So it's basically using Avvigo Plus in CTO PCI. Yeah, we have made major strides both in catheters used for imaging as well as software to analyze images. So from Atlantis Pro to now OptiCross HD, that's an improvement in catheters which happened. And in software, from Clearview to Polaris, and now whatever we have, that Avvigo Plus. So apart from HD IVUS, we have automatic lesion assessment and faster pullback. You have multiple pullback speeds to fasten your imaging, and also table side control, which also helps CTO operator. So look at HD IVUS, how it helps in CTO PCI. See, we have 2 catheters available in India. So OptiCross HD and 6 HD. So this 6 HD is 6 French compatible. It is slightly bigger catheter. So an OptiCross HD, what we can use in 7 French for all the techniques, anti-grade wiring or even tip detection ADR with fine cross, this is compatible with 7 French. But when it comes to 6, we have to take 1 French higher, that is 8 French. These are how to differentiate, this is 5 French catheter, OptiCross HD, this is 6 HD, which is a blue tip one. And regarding image, the key is basically HD improves your visual acuity of, image. So you can see, we can clearly differentiate, media, and also if you look at speckling in the lumen, so there is a significant difference. The image goes almost, if you say OCT, it goes close to OCT in terms of lumen. And most important is, media identification, which really helps in certain things like this, identification of proximal cap. You can see this is non-HD image and this is an HD image, wherein you can see clearly the media. I'll just stop and show you if possible. I think it's not. Okay, so I'll go to the next image. You can see here the media. So, and you can see here media. So it's media is most it's clear in high definition than in 40 megahertz catheter, and that increases your acuity on identifying where your wire is in relation to media. That is the key in IVUS guided cap puncture. You can see both. You can compare both the images. This is the media, which is quite clear, and this is a wire. So when it comes closer and closer towards carina, so 40 megahertz, it becomes very difficult to differentiate from the media. So where it is sitting from media. So HD really helps in differentiating wire location. You can also you can see this is the HD image, how clear the media is, and you can clearly say, you can see this both videos. This is just subintimal. You can see the wire is subintimal. It is going across media, and here this is going. This is a harnett going right in the center of the proximal cap. So this difference becomes more clear with HD, though we have done even with non-HD. And next is identifying true lumen, false lumen, and identifying things where they are sitting in true lumen and false lumen. And you can see this is non-HD, and this one is HD. You see the difference, how clearly you can make out true lumen. See here, this is in false lumen, anti-grade IVUS, and this is a true lumen in which your retrograde wire is sitting. You see here, this is a false lumen, and this is a true lumen. And you can identify, but the image is not so clear. And here it is very clear. And when you are wiring in such scenarios, and that clarity of image helps you in understanding where your wire is and how you can direct the wire. And yeah, this is again, so same thing. So this is the false lumen here, and this is a true lumen, and this is the true lumen here, and this is a false lumen. and you see the
Can you
difference
use the
between the
marker,
two
please?
pictures.
Can you use the pointer? You have a pointer with you.
You just use the pointer to point out
I'm using
where
arrow,
the false
but-
is on both
sorry,
images.
sorry. Here arrow is visible. I'm thinking, okay. Yeah, see, this is the false lumen here, and this is a true lumen. And here, this is a true lumen, and this is a false lumen. So, overall, the clarity will be much better in HD. And you can see this is a case, mid LED CTO with an ambiguous cap. We did an IVUS guided wiring, and subsequently we did a parallel wire, but ended up in compromising, the true lumen distally. So that's when typically, IVUS guided wiring helps. And see here, so my catheter is in false lumen, and you can see this is a true lumen. And you can clearly see the media. So your edges are very clear, in HD, and you can wire it. Now you can see once I wired, this is a wire which is in true lumen. So you can see now again here. So this is a true lumen, and this is a wire. So which is going from false lumen to true lumen. That's the entry point of true lumen. So, and you can see this is a Harnett wire, so which I wired into true lumen, and subsequently you can advance your microcatheter into true lumen and come back to your workhorse wire, and you can finish procedure. You can also see a tip detection ADR, which can be done. So you see this is, wire is completely subintimal, and you can see this is an IVUS optic cross. So even TD ADR can be done with optic cross. So I can see how clear the media is, and how clearly you can identify this is a true lumen, which is completely compressed, and this is a false lumen, and you can wire much easily. This is the wire you can see, which is in true lumen, and coming back to false lumen. Basically, I wired, and subsequently, you can finish. So this is the first case report from North America, and this is another case report from European experience on tip detection ADR. And IMH, this is one more thing, how clearly, see, when there is an IMH, we tend to create fenestrations in the flap before we stand. And you see the IMH here versus IMH here, HD. So your flap is quite clear with an HD. So when you make fenestrations, I'll show you how it looks. This is HD, this is non-HD. And this is a case where I used cutting balloon Wolverine to make fenestrations. I think I'm not able to move the image. You can see this is still, almost circumferential dissection. When I come proximally, this is a fenestration. So it's a clear fenestration. So you can make out fenestrations also much easily in HD, which makes you, more comfortable in going to your next strategy, that is stunting. So once that is done, see, you can see this is the flap, and this is where the fenestration is. Discontinuity in the flap is clearly visible. You can see this is the discontinuity in the flap. So coming to these things, automatic lesion assessment and fast pullback. And these things we use, once the wiring is done, not, during the course of wiring, which we know the Achilles heel of CTO PCI is the time and radiation dose and, contrast. And time you can pull down, by using this newer software and, newer high-speed catheters, so which reduces your workflow time significantly, mainly because of ALA as well as faster pullbacks. I think I can skip this. Yeah, these are the various pullback speeds which are available without any compromise in the image quality. And the table side control, again, see, for a CTO operator, see, it's often difficult, what your imaging guy is trying to tell you. If you have something on your side with which you can see your images, whatever image you want and whatever you want to interpret, it always helps. So having a table side control also, much better for a CTO operator. So overall, this new thing, Avvigo Plus, adds value in CTO PCI. HDI was sharpens, operator visual acuity for media, and true and false lumen, and which facilitates IVUS guided cap puncture, IVUS guided antigrade or retrograde wiring, tip detection ADR, and ALA and faster pullback reduces your procedural time and also to some extent your radiation dose, and table side control facilitates single operator control. Thank you.